in my office, I have something, and I'm going to do this slowly because I always trip over it, but we offer 3 kinds of services: good, fast, and cheap. But you can only have 2 at a time. Cheap and fast will not be good.
Yeah.
And
Good and cheap.
good and cheap will not be fast.
I like that.
So I read it better off my wall, but I don't have it on. That's why I keep it on my wall, because I always.
We can superimpose it back
That's
here.
right.
There's a major crisis facing healthcare facilities management. We have aging employees, aging buildings, and aging infrastructure. We've created the Healthcare Facilities Network, a content network designed specifically to help solve for these 3 pressing issues in healthcare facilities management. We bring on thought leaders and experts from across healthcare facilities management, all the way from the C-suite to the technician level, because at the end of the day, we're all invested in solving the aging issue. Thanks for tuning in. Look at our videos. You will find that as a theme across our content. This is the Healthcare Facilities Network. I'm your host, Peter Martin. So hello, and welcome to the Healthcare Facilities Network. I should actually put on the footage of what occurred before we started taping so people could see that this is actually a engineer, architect that I'm sitting with. This is Jeff O'Neill. I am Peter Martin, host of the Healthcare Facilities Network, here on site at the ASHI PDC conference in Houston, Texas. Jeff, who are you?
Who am I? I'm Jeff O'Neill. I'm the Vice President of Plant Operations at Robert Wood Johnson University Hospital in New Brunswick. We're part of the RWJ Barnabas Health Network. We have 13 hospitals, many outpatient, and really serve the patients of New Jersey.
Excellent. Jeff, thank you for appearing. As you may recall, Jeff appeared last year, same PDC conference. Where were we? Atlanta. And so Jeff has kindly joined me today from on-site. This is day 1 of the PDC conference. And I want to start out first, Jeff. We went to a session this morning, somebody from your organization, Kelly Miller, was there, and was talking about some of the biggest issues that healthcare organizations are facing in 2026. They talked about staffing, capital planning, and I can't remember what the third one. Staffing, capital planning.
Access to capital, transitions on projects, and getting the right teams in place is really the focus of that.
Yeah, and so I want to start with Jeff, if you don't mind, with the capital project. So what would you say, Jeff, the state of capital projects is in 2026? Are we moving forward, still in a pause? What do you see?
So my position in New Brunswick, really, I'm over both capital management there and facility operations. So deferred maintenance is a area that I'm really focused on. We touched on it in that session earlier today, but those are highly impactful, high-cost projects. Harder to do than the new builds that you're seeing a lot of, where you're basically creating either a new specialty hospital, a new hospital, or at a new site, but working within the existing hospital. We talked a little bit about the deferred maintenance and upgrading what we have. Those are highly disruptive because we still need to maintain operations within the hospital, particularly at a campus like New Brunswick. You can name any hospital with a active ED, with an active, any level of trauma program, anyone that's serving a big community. You really need to keep bed availability and nursing efficient in their operations. And when we come in and do these deferred maintenance on systems, particularly at a larger scale, you really have to pay attention to the level of disruption you're creating. And based on that could stretch things out for a very long time because it has a huge effect on the project.
And so are those disruptions, how do you deal with them?
Well, we plan as much as we can, and we try and engage the affected groups as best we can as well. We particularly the nursing group, because if I'm taking a group of rooms out of a floor or even an entire floor to do some deferred maintenance, either on an air handler unit, plumbing systems, electrical systems, they have to think about their staffing. They have to think about what does a unit look like if it's a 30-bed unit and it's reduced by 10 beds for me to do my thing on these systems. That really affects the nursing ratios. We have to pay attention to that because that's the front line of the care, and we can't really mess with that. And it's all about care efficiency. There are financial impacts to that, to proper staffing and nursing ratios and how we take these beds out. Of course, there's financial implications, but what it really boils down to is how efficient are we delivering the care when we're trying to upgrade these systems.
You are an architect by education and practice, right? So
Correct.
When did you transition into the facility ops side?
I actually, at another academic medical center, I transitioned in the middle of a project that I was manager of. It was a ambulatory building, base exam rooms, a big scale though, where I was the lead project manager. And right in the middle of that, the hospital that this down the block, it was going to be a facility of this hospital, there was an opening in the director of engineering. So I had interest in that. And, after support from leadership to make the transition, I took that job. And I immediately felt, when I was moving into that new building, what was I thinking on some decisions from a maintenance perspective in order to hit my schedule, to keep my budget, to make decision within the context of the project and the planning. The big piece was engaging with the facility group and making sure we're making a right decision there. So very important lessons were learned in that transition that I still carry with me today. And that was in 2013.
2013.
Okay, so roughly half my career has been planning and design. The other half has been facility operations, but informing planning and design.
So that's very interesting, that answer. I don't know if you saw, we released on the Healthcare Facilities Network an episode with Dennis Ford, Mike Hatton, Patrick Murphy, and Diana Candler talking about zombies in healthcare. And one of the zombies we talked about was the relationship between PDC and FM and the silos that developed and how we need to. Your answer was really interesting to me that, when you jumped over onto the facility ops side, it was like a light bulb went off.
Sure, it sure was.
No, so tell me then, if you can think back 13 years ago, like when you were PMing the projects, when you were on the PDC side, what was the thought of facilities, transition to operate, like all the impacts that you were like, holy cow.
Well,
what was the thought behind that?
I've always felt it was important to engage the facility staff. Even when I was at a firm, when I started my career at the VA, I worked in that department. I couldn't help but coordinate with those groups. So I learned early that coordination is primary. Mm-hmm. The difference is we have a construction schedule. We have regular job meetings. The projects take on cultures of their own. They get into rhythms of their own.
Yeah.
The job meetings. A facility operations group is on a different rhythm. So the simple approach is, well, we invited you to the meeting, but you didn't come. Well, maybe the meeting was at a time that they couldn't come.
Yeah.
Or I couldn't get the right person there. So the biggest lesson that I learned at that time was, how do I engage on the construction project and keep that going? I thought that if I was taking over, everything was going to come together and we were all going to be super happy. But that's not the case at all. The biggest part of my job, and it remains the biggest part of my job, is how do I strike that balance? How do I get the input that I need on the project side to make a good decision that's going to last after we open the building, and make sure that we can maintain it efficiently as well, to and bring those two rhythms together.
Yeah. I love that answer. That's fantastic. And why do you think, so I'm at, like, going beyond your role, just think, because you're heavily involved with your ASHI work, you're involved codes, etc. You see a lot from across the country.
Sure.
Why do you think that those silos develop between the PDC world and the FM world within the hospitals when projects are going? What's the cause of that?
I'll start by saying it's probably schedule is the biggest thing. I can't think of a project I've worked on in the last 15 or 20 years that wasn't quote unquote fast track.
Right.
Like every project needs to get from development, the spend of the capital, to seeing a patient and providing the care just by the nature of the business, that there's a need. So they need that need. And we, on the construction side, need to make sure that we deliver when we say we're going to deliver. So I think because of that dynamic and all the expertise that you have that's coming into a project, that developed like that rhythm of a project, that you're moving efficiently in terms of the project itself. Decisions are being made that are being carried forward. We talked a little bit earlier in that session about changes that come and the clinical groups wanting to make a change, but that's their nature.
Yeah.
I learned early on from someone that's out at FGI, Dr. Paul Shackelford, told me that, or he told a group that I happened to be sitting in, that a clinical team doesn't respond well to that linear decision making. Like a decision they made 3 months ago may not stick now because a clinician is always reevaluating. The situation is always changing with a patient, sometimes every 15 minutes, sometimes every hour, every day. So the mindset is, how can I do it better? How can I make this solution better? So in a construction project, I make a decision, it's in SDs, schematics.
Yeah.
By the time I get to DDs, they're like, you know what? I think we can do it better if we do X, Y, or Z. That throws an engineer, architect for a loop.
Yeah.
Oh, you mean I have to go back
Yeah.
and now sort of quote unquote redesign? That's where the ad services stack up. But that is the core of the nature of our clients. I have clients working where I work in the hospital. It's the nursing teams, it's the patients, it's the care teams, it's the doctors, it's the supports, it's the ancillaries. Everybody that has a stake in the building is my client, and they think differently, and you have to understand how they think to fit them into the process.
You're a psychiatrist too.
Oh my gosh, I don't fancy myself that. I probably need one or two.
You
or
are
10, but it's just working with people, understanding who you're working with.
Well, you know what's interesting with that answer when you were talking about schedule, and then you went into kind of not changing my mind, but reevaluating. I found that, and this is obviously not a society podcast, and I don't know if it's because maybe I'm paying attention a little more now, but I've noticed that people are criticized, whether it's sports, politics, you name it, healthcare, when they make a decision, and you may have clear goals 4 months ago, but but you change down the road, and it's sometimes seen as a criticism, but sometimes you're making that change not for the hell of it, but because you're reevaluating information. And I think sometimes we try to stick people. You originally said this. You got to say it.
You didn't think of that.
Yes.
Why didn't you think of that? So, but you work with who you're working with. You make the best decisions that you can. And a big part of my job too is if there is especially a late change in a project, it's to understand how the decision was made to begin with.
Yep.
So the big conversation is having patience enough to walk the person that's recommending the new change through how we got to where we are. And I'm not perfect in that one, but I find that developing that understanding helps.
Yeah.
Particularly if someone, especially if it's a long project that wasn't around for that initial decision making, where they feel that they're the quote unquote fresh eyes looking at it, but it's at a point in the project where the fresh eyes doesn't have much leeway to make the change.
Right.
But bringing them along to understand how the way it is and have it make sense is helpful.
Do you find Now that you're on the facility ops side, the architecture side, is there one side you like more than the other? You still like it both?
I still like it both because one informs the other.
Right.
I mean, seeing at the PDC, the student challenge, it's just so invigorating to see new solutions coming in, new mindsets, and trying to solve these problems that way. One informs the other. Bringing folks along to get into a new building, the excitement of a new building, of coming in. Sometimes the excitement leads to frenzy, where everybody wants to do the right thing and make it the most optimal space possible. But I really, in my vision of my career, I love where I am.
Nice.
Because I can work with both ends. And even when I originally did make the switch, I never sort of completely left the Capitol, but found that the work is getting those folks together. And that's what I really enjoy that way, is to make sure that balance and those rhythms can come together at some point.
You talked about deferred maintenance kind of right at the very beginning, but before we jump to deferred maintenance, I want to go back. So you missed the ASHI Innovation Conference because you were opening a new building in the summertime.
Cancer Center, right.
So you mentioned transition to operations in your last answer. Tell me, what are one or two things from that transition to operations when you open up? Were there aha moments, or was there anything that stuck out as you guys operated that new building, as you opened it up and started to see patients?
I think that, as you open a new building, you're working with your team. And it's a pretty finite team up to a certain point. When you get into the transition operations, more and more people are laying eyes on it. More and more people are becoming familiar with it. More and more people are coming in that worked in a particular setting for about 20 years that have a certain way that they worked. So I'm a fan that, what made me open my eyes was that transition planning starts way before the building's ready to walk through in a tour. That there's a lot you can do in existing space to start change mindsets, pick up on ideas that came out in the design and implement them in their existing space. I think that's always a big opportunity, a huge challenge, but get people thinking about it early on, and then they can come into the building.
Is that, Jeff, even over and above a mock-up?
Oh yeah. Without question.
It's
Without
you do your
question.
mock-ups, but then you also get them out during
The mock-up even still seems like it's this sort of little playground that we get to move things around.
yellow sticky.
But then I'm going to go back and I'm going to do it the way I've done it for the last 20 years. So it's breaking the boundary of the mock-up and starting to implement really just operational changes that maybe doesn't require a lot of construction, but just helps change the mindset. Will get people thinking a little better coming into the building and bring them in. We tried that. We had success in some areas and maybe not as much success in others, but it stuck out to me that the importance of that exercise really has a lot to do with the success coming into a building.
Did that exercise create some, we're all human, but did that create some frustration on the part of either you or the project team, kind of like bringing in that clinical, or did you guys always see, and it's kind of like the keynote that we heard this morning, did you keep your eyes on the final prize you were looking for? Listen, we need this input now so that we're not dealing with these frustrations when the building opens up.
Well, the eye on the prize concept was sort of the beacon that followed. So we picked our shots. We took got a lot of feedback in the transition. I ran a lot of lists.
He must have.
from different folks. And then from a leadership perspective, I had a ton of great people I was working with. As that building got staffed up, the leadership was amazing to work with, where we were able to prioritize and to say what's important. Compliance for DOH approval was primary. Does it threaten that? If it threatened that, then we needed to make a change. Which were few and far between because we pretty largely had a compliant design. Very, very small things. But then there was the level of operation on if it met up with the goals and the expectations of the broader leadership team. So having that team to discern all that is huge.
Yeah.
And also not do too much in the early in the run up, because some of it may come in sort of a panic. So having support, and this is huge. I had support when I said, I don't want to make that change. Let's give it time after we move in and we can revisit it. We're actually starting to revisit some of that list now because we're going on a year.
Yeah.
Everyone's settled in, and I could say that a lot of that list sort of went away because people sort of then they're in it, they're living in it, they're picking up on what we were laying down, and we're able to function. But some things stick.
Yep.
So you have to be ready for that too.
If you like this video, please like and subscribe to the network. And more importantly, share it with your colleagues in the healthcare industry. Together, we can solve the aging crisis that's impacting all of us.
I haven't done project management in a long time, fortunately. I did the recruiting. Now I do this, which is a lot more fun because I get to talk to you and hear your issues. But I just still remember when we were doing those projects, when you open them up, I remember getting the email after email and the calls, and everybody wants something. And I remember it creates frustration on the project team. And then sometimes you have the people, all right, I'm going to take care of it just to get you off my back.
Right.
That's a great piece of advice, to have that support to kind of parking lot it and then revisit it, because it is a very emotional time.
It's an emotional
You don't
time.
know the space.
We heard from our keynote speaker today about, tough conversations and procrastination, a form of procrastination. Oh yeah, just do it
Yeah.
to shut this individual up
Exactly.
or whatever. But that could be a huge mistake. And the rigor we put into it, I called it a parking lot. People got sick of hearing about my parking lot. But I had support from key leaders to say, we're going to give it time and get, settle in, do what you need to do. And I could tell you, if we made changes on the fly, a lot of them would have been put back to the original.
Yep.
So people do come around, and that's a faith thing. That's a very extremely difficult conversation to tell somebody, no, we're not going to do their idea that in their mind they think they absolutely have to have. That's where my code compliance pieces come in. Having the regulatory team help me with that is awesome. Like I said, the leadership, I build another one with that same group. So but that level of support and coordination with that leadership was huge.
How difficult was it for you to get that support from up above? What was your messaging to them?
I think
when you
that
asked
it was, so I'm lucky in that I have a receptive leadership. I don't think lucky, like I'm sure there's tons of it around everywhere, but just being clear, being above board, keeping them informed on the issues, keeping them engaged in the project. It's not just something going on across the street. All paved the way to get good support. Having that team understand how the decisions were made and the zeitgeist of the project also helps. That they understand what's going on. So if I'm fielding changes from people that are just sort of coming into that transition process, you have to keep in mind they don't have the history of the project. They weren't there at SDs. They weren't there through the life of the project and those or rhythm of that project. They're coming in sort of in a different time. So there's that kind of patience you need to have too.
Yeah, that's why project work is so multifaceted, right? You're talking about basically a project historian. So you kind of, because you're always going back and
I myself came to the project after it was designed and approved by the state. So when I started in 22, everyone thought I was going to come in and start making changes. But my main questions are, what are the key principles of this project? What do I need to promote to keep it going in the direction that we're already in? I understood that we were not at a point where we could make changes.
That's a great leadership style, because I'm sure you've dealt with it. I've dealt with it. I'll bet everybody listening has dealt with it. When you have somebody who comes onto a project team and may very well be qualified to be on that project.
Without
And you
question.
are, without question. But you're a pro, and they come in shooting,
Right.
because they think it's almost, we got to change things.
Right.
But that approach is the exact opposite.
So, and it's a discipline.
Yes.
It's a just knowing where you are in that culture of that project, and understand the goals of and not insignificantly the schedule
Yeah.
that everyone's keeping an eye on, especially a big investment like that. You really have to approach it that way.
That was such a huge. They talked about that this morning, project schedule, and this could really be a podcast unto itself. But so many of these project schedules are unrealistic from the get go, right? And you're
Sure.
and you're just on it, and that does not causes repercussions down the road.
Well, yeah, I have in my office, I have something, and I'm going to do this slowly because I always trip over it, but we offer 3 kinds of services: good, fast, and cheap. But you can only have 2 at a time.
Good,
Because
fast, and cheap.
good and fast is not cheap.
Yep.
If you want it fast, you're going to pay a premium for the schedule.
Yep.
Fast and good, or I'm sorry, yeah, fast and good, cheap. See, I'm already screwed.
Well, cheap and fast you could do, but it's not going to be good.
Cheap and fast will not be good.
Yeah.
And
Good and cheap.
good and cheap will not be fast.
I like that.
So I read it better off my wall, but I don't have it on. That's why I keep it on my wall, because I always.
We can superimpose it back
That's
here.
right. That's right.
So just a couple more questions, because Jeff has to eat, and I do want to get him out of here. But let's go to deferred maintenance for a sec.
Sure.
If you don't mind. It's not sexy like the guys were talking about this morning.
Right.
It's difficult to get funds.
Right.
It goes against the mantra of fast, 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 I would think too, right? Because
Right.
So how do you've identified deferred maintenance? It's a priority for you.
Mm-hmm.
How did you get there? How do you manage deferred maintenance? What's your secret sauce if you have it?
So there is no one with a bottomless pit of money. Most people think capital projects is like Santa Claus coming to town, that you ask and you receive. But when you're discerning deferred maintenance budgets and capital budgets, I learned from, I've had many people that I consider mentors. One said to budget is to choose. So what you're doing is you're choosing the highest priority system that needs replacement. What's imminent in failure? There's a risk factor to it as well. Like, how impactful will a system failure on this be to operations? Because the key thing with hospital facility operations is to minimize disruption to care. So if I have systems that are keenly failing, like the VISO award winner from Morris Lister, they had frequent power outages that was affecting care. And so that's a driver to do an intervention that they did by creating a plan. We did some similar things on our campus because of the age of the infrastructure. And I can tell you from even the board level, they're very interested in the infrastructure of the existing hospital, almost really as much as any new development coming. So
That's a credit.
so it is, and we're lucky to have a strong board that way that understands that, and therefore the support comes. But it's not an unlimited support. The resources get lined up. It's up to us to implement and execute and make sure that we do it in an efficient way that we talked about already. That doesn't, put too big of a burden on the care mission.
Yeah. Last question, Jeff. I have to ask you about AI. How do you see it evolving? How are you integrating it? Number one, now, and how do you see that evolving? We're here at the PDC. I actually took account. I thought there would be more classes like with an AI focus to them, and there weren't. There were some, not a ton. How do you see it playing out over the coming years?
And I'll say, just from my little world in New Brunswick, there we're really not doing much with AI itself, as to say, that's where we're turning that over to AI. Where I see opportunity, if this is even possible, some predictive analysis on those deferred maintenance projects to help me prioritize.
Yeah.
Like AI may pick up on something that I'm not, and I huddle with my facility team, when I huddle with our infrastructure capital folks at the corporate level. How does AI inform that? I see AI having a role when we're talking about maybe more highly technical things that are more factually based, that are backed by science. From a design standpoint, the AI is only as good as the information that it's looking at. So, what kind of quality measures are considered there? So I see it coming more for our systems just to help us boost monitoring it. Like I talked about an example the other day in our evidence-based design class where, from a security system, you see cameras everywhere, but they're used more for investigation purposes, not really to protect you in the moment. But could AI assist as being that person that's watching hundreds of cameras to see something unusual going on and then bring a focus to somebody to start to dispatch security to a certain area? Sudden movements, groups of people coming together very quickly, people moving in a sharp way to suggest they were pushed or hit.
Yeah.
It could AI help with that and understand those movements? That's one example that I could see AI not taking somebody's job, not taking our place, but to help fill those gaps that we talk about all the time, that we just don't have a solution for, even if I had all the personnel available in the world to do it. But things like those safety elements, how can AI help buttress our responses and shorten the time to get to somebody in an issue that way? So, like I said, we're really not diving in certain ways, but you see everything. And how can it help? Those are some of my thoughts on how it can help.
And that's an interesting answer. I was thinking, as you were talking about the AI and where it can help, I was also thinking back to the beginning of our conversation and everything you talked about. Because the fear is AI is going to take my job. AI is going to take the job. But especially I think in healthcare facilities, and maybe being a little bit parochial with it, but the human touch that you employ, the way you deal with the clinicians, the way you bring the project together, that's a skill. And not everybody's got it. And I don't know that AI can do that. And because at the end of the day, that's the thing that makes the success.
I guess that's what I'm saying, is that AI is more like a tool than to gobble up FTEs. There may be some industries that it does, like financial analytics. Even in my early career as an architect working in a firm in a print room, and remember what they are, you're running things through. But I also did a lot of submittal review, and I also did a lot of filing. And now that all those files are electronic, the AI might do that, just organize it for you and tee it up. And so I see it more as a tool. And if you're entry level in a career, you need to know how to run the tool.
Yep.
So that may be a small, like almost short-sighted vision, but that at least I could see that as the next step for AI in our industry.
So when you're talking about the plans, I was thinking, remember you'd get the big plans delivered to your project office and you'd cut them up. They were bound. You cut it open, they'd follow. It was kind of fun having the pages.
And I had to, you put them in the diazo with the ammonia, and you're in a room without a window with a fake little fan that's acting as an exhaust. And you printed them out, you rolled them up, and you drove them out to the state, and you had to lay them out. They sat there and reviewed it that way. That wasn't too long ago. Change that. But so those are the things, and actually just seeing the student challenge. These kids are ready for a higher level than running prints and filing submittals. They're thinking. Yeah, we want to harness that. We want to get them the tools to be able to do that.
Well, it was fun. My youngest son Patrick is he's a construction manager major at Virginia Tech. He's a freshman and he wants to do an internship. And he just came home for spring break. And he said to me, like, he's been doing some of the PM stuff, we kind of learning about it. He's like, Dad, I don't think I want to be a PM. He's like, I'm not really big on the data, the Excel spreadsheet, the input. He's like, I think I want to be a super. And so
Interesting.
I said to him, you know what? It's all there. You just kind of investigate it, and you're young.
Sounds hands-on.
But
So
I would
that's-
never be
there's
thinking
no
that at
problem
18.
with that either. Yeah.
At 18, that was not
Sure.
my thought.
Sure.
But anyways, Jeff O'Neill. Jeff needs to eat. I appreciate you. You're always
Always a
good
pleasure
guest.
talking.
guest.
Thank
So-
you so much for having me.
My pleasure. Jeff O'Neill, Vice President, RWJ New Brunswick Campus.
RWJ Barnabas.
Brunswick Campus. I always forget the Barnabas. Sorry if
I
I
forget the Barnabas, man. My bosses will get mad at me.
I try to get you in trouble. Peter Martin for the Healthcare Facilities Network. Thank you for watching. We'll be back with a future episode. Take care. If you want to be a guest on a future episode of the Healthcare Facilities Network, go to healthcarefacilitiesnetwork.com and let us know who you are and what you want to talk about, because together we can solve this critical aging issue.